Good morning, everybody. Sorry we're starting a few minutes late. My name is Manal Faqih. I represent the Faqih Health Group in Jeddah, Saudi Arabia. It's an educational healthcare model, and I chair as scientific chair in addiction and rehabilitation medicine. Today we have an amazing group. It's about the development and implementation of new addiction care system in the kingdom in general, and hopefully the GCC. Together with Professor Hamad, would share this part. We're going to have Professor Richard Rowson speaking about comprehensive systems of addiction treatment. It's more than just a bunch of programs, he calls it. We're going to have Dean Carmel Clancy. She is working about workforce sustainability in Saudi Arabia and all that comes underneath that. And we have Dr. Mark Potenza, who is speaking about current education and training needs in behavioral addiction, considering all the jurisdictional contexts. I hope this will turn out to be as nice as we all expect it to be. Thank you for being here. We'll start. I'm just going to have to say that I will leave short because I have a flight to catch. Thank you all for being here.
Okay, thank you. We've had a lot of meetings this morning already, so I'm just getting myself a little unflustered. A group of us have had the great opportunity to work with Dr. Manal for several years now in understanding some of the treatment needs in the Kingdom of Saudi Arabia and providing some suggestions for services and workforce development that can be done for the Faqih group. I would be negligent if I didn't mention that none of this would be happening without my esteemed and very appreciated colleague, Dr. Tariq Abdul Gawad, who has been working with Dr. Manal for many years and has sort of organized this effort. So our thoughts are with Dr. Tariq. The Kingdom of Saudi Arabia is a very young society. The average age is around 18 years old. More than half the population is below the age of 18. So they have a very young society. It's gone through substantial change. For any of you who have been to Saudi Arabia, say 10 years ago, if you visited today, you wouldn't recognize many of the cities. It's been remarkable change that's going on. Now, while this change has had many exciting and very positive developments, they brought some new environmental stressors to many of the young people who are growing up in that society. Reduced traditional stable influences on individual behavior, such as the family and the religious community, and increased influence from new sources, the internet, social media, increased availability of substances and misuse. For these reasons, many of the young Saudi Arabia population is increasingly vulnerable to behavioral and emotional problems, such as substance use disorders, gambling problems, and psychiatric disorders. The Faqih Health Group has a reputation of providing, as I think Dr. Manal noted this morning, they were given the highest rating for private healthcare services in Saudi Arabia by a number of groups, and are well known for having very impressive, very modern hospitals and health centers. Although the development of the substance use area and psychiatric services have been less well developed, and that's what we're talking about helping them provide. So to meet the needs of this population, the healthcare system and they have a College of Medical Sciences affiliated with Faqih, led by Dr. Manal and by her brother, Dr. Mazen, in developing this whole system of healthcare. So we've worked with them to produce a strategic plan for some service development. And the activities will include what I'm going to present, which is some ideas around the development of a service system, what Carmel is going to present, which is some information on the development of a workforce, as you'll see, this master plan that Tom McClellan and I have outlined for implementation is a great pie-in-the-sky concept, but will never happen without a massive workforce development effort to get the people to deliver this care. There's also going to be a program of research. Proposals have already been submitted to get some research projects going, and the group will also be doing an awareness and prevention activities. My presentation is going to consist of I'm going to do two pieces. One, I'm going to do Tom McClellan's talk, which is I'm not really looking forward to because only Tom McClellan can do Tom McClellan's talks, but I'll give it my best. I'll then talk about some of the structural frameworks we're talking about for service development. Carmel will talk about workforce development, and Mark will have some comments about cultural adaptation and behavioral addictions. So that's what we hope to cover for you in today's events. Okay, I don't know if any of you know Tom McClellan or who have heard Tom talk, but he has some very strong ideas about how our 50 years of experience in developing addiction care. Tom and I both started almost the same year. He was in the military for a year before me, so I actually have been doing addiction work one more year than Tom, although he's older than me, slightly older. I told him that I think he's 3 months older than me, but anyway, I'll give my best impression of what he tries to convey, because for the most part, I agree with it. Not all of it, but so let's start with the concept of addiction as we're conceptualizing it, and certainly for the case that we're making for Saudi Arabia. These are some of the elements of addiction as Tom describes it that are very certainly contained in the DSM and the ICD-9 or ICD-11. And Tom has made a career the last 20 years of writing about how addiction has a chronic illness requiring chronic long-term care, ongoing support. However, our treatment system has looked at it as an acute disorder. We're doing short programs of care. And many of this is, there's a variety of reasons for this, philosophical, financial, and that it's, as the United States has set it up, the substance use disorder service system is separate from all the other pieces of health care. I actually did a survey probably about 10 years ago in the state of California, asking addiction providers where their referrals came from. Where do their patients come from? Fewer than 5% of the referrals came from the healthcare system. 95% of them came from the criminal justice system, from the social service system, from the housing sector, from employment groups, mostly criminal justice. Very little in the way of awareness of the addiction system from the broader healthcare system. And that really has limited many of the services and the way we think about addiction care. And as he said, this idea of doing programs rather than an ongoing continuum of care has been the most common model we've seen. And as in the United States, much of what we do is driven by who the payer is and what the payer wants. And in many cases, we see that the purchaser buys pieces of treatment, individual components of treatment, whether it's maintenance medication or outpatient behavioral treatments or detoxification or residential care. They generally are fragmented and not put together into some kind of rational system. As Tom points out, very few of our general medical professionals have extensive training in addiction. Now that's changing. I mean, ISAM has done a great job in the United States of raising the awareness of addiction, certainly with the 20 years ago, the emergence of buprenorphine as a mainstream medication in the United States, much of that treatment is now being done by general practitioners, not by specialty care people. And I've seen this in a lot of the work I do in the United States. It's the dramatic changes over the last 20 years have been day and night. I mean, I live now in Vermont, which is a small rural state. My primary care doctor has a clinic about 3 miles away. I go into the clinic to get my blood pressure checked or get my medical care, and there are often 2 or 3 people waiting for their buprenorphine in the same waiting room, in the same clinic that I go for medical services. That never happened 20 years ago. The buprenorphine really has changed everything. And I think and Tom had a lot to do with that. When buprenorphine was being licensed in the United States, there was a big debate. Should we keep it only in the specialty care addiction system, or should we allow it to be moved into mainstream medicine? And the decision was made to do that, and I think we've benefited tremendously in getting addiction, substance use disorder care more integrated into mainstream medicine. Also, with this issue of having the system so fragmented, with one group doing the detox, another group doing maintenance, another group doing residential care, there's been very little in the way of development of patients flowing through a continuum of care, stepping down from residential to outpatient to some less intensive support. And that really has resulted in much higher return to use rates, people not really getting optimal care that produces long-term recovery. What we're talking about, and what has been sort of the conceptual framework for the service system development for the FAQI group, is this idea of trying to develop the care in a way that we think conceptually it makes the most sense. And that means getting primary care doctors to be aware of substance use disorders, to screen for substance use disorders, to bring the treatment into the mainstream of the healthcare system. And so the focus of the treatment is not on how to set up a program, but what are we trying to accomplish with this treatment, and what's our end goals for what we want to accomplish. The role of primary care becomes increasingly important, which has always been virtually irrelevant to substance use care until the recent changes basically with the advent of buprenorphine care. But so we're doing more training with primary care doctors on screening, on recognizing substance use disorders, to being able to provide ongoing support for them. And in the clinics where they provide primary care, having personnel trained so they can provide ongoing support to people who are receiving substance use care. Certainly electronic records need to reflect this new way of thinking about people with substance use disorder. Residential care not being responsible for recovery. Residential care being responsible for initiating the reduction in substance use care, providing assessment and treatment for major medical and psychiatric disorders, and responsible for successfully transitioning people to the next level of care. I've been doing work in California on this for about 40 years, and we have these initiatives where we're going to create continua of care. Nothing changes. The residential programs still do the residential stuff, and the outpatient programs do the outpatient stuff, and the OTPs, opioid treatment programs, do methadone maintenance, and buprenorphine is done somewhere else. It's all still very fragmented. When you're working with people in the residential programs, they focus very closely on what's happening inside that structure. But the day their patient is discharged into the community or into the next level of care, it's no longer their problem. It's no longer their patient. And one of the things we've done a very poor job of is figuring out how to make those transitions and make them work. As Tom says, recovery is the goal for outpatient care. The outpatient treatment, which has been certainly widely used and widely discussed, and we have lots of interventions that are developed for outpatient care. It really has not fully been recognized as that's where most of the recovery occurs, is out in the community when people are living in the community. And when we tend to do, well, we do this big intensive thing that costs a lot of money in the residential setting, and then we do some kind of whatever that happens in the outpatient setting. McClellan's point is that should be flipped on its head, that we should be spending a lot more time and attention to what goes on in the outpatient setting, because that's where you really help people develop recovery. And that's what the goal of treatment with Tom's thinking is. By the way, Tom's not big on harm reduction, so you don't see a lot in here on harm reduction, but which I think is a mistake. So that's one of the places I disagree with him, but I'm giving his talk, I'm sorry. And his model of developing abstinence-based, models of developing recovery, abstinence-based recovery, which is sort of the model that the United States has used for the last 70 years as the primary model of recovery, and then medication-based recovery, which for those of you who have been around for many years, when I started with methadone in 1974, we could use methadone for 6 months. I think it was in 1978 we could start using it for 1 year. And then it started to increase to 2 years, and now it's, obviously we use it for as long as the patient needs it. Similarly with buprenorphine went through some stages like that as well. And now it's kind of accepted that these forms of recovery, whether with or without medication, are programs, are processes that go on for a long time. They're not limited to any kind of time frame. And recovery is something we're trying to instill that will be part of a person's life forever. And that the patients who desire to stop their medication, certainly that's what it's their choice, but we certainly want to continue them in ongoing care even when they stop taking their medication. That's as good as I can do with Tom's words, but hopefully I give you some idea of what his rationale is, that acute care for treating a chronic illness is a misfit, and that we've developed all these pieces of treatment, but we haven't ever developed an ongoing program for recovery. Okay, so here's what, based on that conceptualization of addiction, here's what we're thinking about. The Faki health system that's currently in place is made up of a set of hospitals. They have, you now have 4 major hospitals. Jeddah, Riyadh, one in Dubai, and a new one that just opened in Medina. I'm not going to talk about the Medina one because that one just was opened. These are medical surgical hospitals. They have a small department of psychiatry, which is, we've talked to several of the doctors there. They do some work with people with substance use disorder, but nothing very well defined. They're developing a new center called Mabar, which means the causeway. Okay, I'm sorry. Tarek told me that, and this is going to be a center of excellence. And I'll explain in a minute exactly how that's going to work. But what they also have in existence now are some outpatient clinics in the neighborhoods, in the communities where they have their hospitals. So they have the existing now is a hospital and some outpatient clinics. We've done some work in the United States in disseminating buprenorphine throughout some geographic regions where we've used a hub and spoke model, where we have a central clinic that has addiction staff, addiction psychiatrists, addiction-trained nurses, counselors and psychologists in these centers of these hubs that we have. And then we have spokes out in the community, outpatient clinics general practitioners. My clinic that's 3 miles from me is a spoke, where buprenorphine is provided by general medical staff who have much less intensive training, but they're great at providing the support and care that needs to go along with buprenorphine. These aren't addiction programs, they're primarily medical clinics, and that's what we see in, that are connected to the Faki hospitals. What we're hoping to do is to, using what Tom described as a model for care, we're hoping to build an extended hub and spoke system around the Faki hospitals with their outpatient clinics and with the Mabar Center of Excellence as our main major resource for residential care and for treating patients for co-occurring disorders and dealing with the more difficult patients. So again, the recognition of substance use disorders and mental health disorders as chronic conditions. We're hoping to promote recovery in these systems. Residential rehabilitation care frequently is an essential element of care, but not sufficient. Outpatient settings provide long-term services necessary for sustained treatment effects and recovery. One of the things we have not spent much time on in the United States is how do you transition people? If you look at the data from California on the proportion of people who transfer from residential care into outpatient care, it's less than 20%. So only about less than 1 in 5 people who gets a residential treatment, 28 days, 90 days, whatever kind of residential experience, less than 1 in 5 actually continue in ongoing support in the community. That's a ridiculous missed opportunity to take the benefits people get from residential care and extend it into long-term recovery. We're hoping to really work on that as one of the central elements of what we develop. We want to use evidence-based care, including medications, and we want to apply the 21st century technology that's currently available. I talked to Tom a couple of days before coming here. He said he's been looking at some AI counseling protocols that he's finds very fascinating. We've done a lot of work with app-based care where patients have substance use disorder programming on apps that they're able to use, and also the use of telemedicine. All of these ways to make treatment more accessible and make it more available to people in the communities of Saudi Arabia. So this is kind of how we conceptually see it, with the Mabar Center as the center of excellence, where we would have much of the research would go on. Many of the more challenging patients would start into treatment, would get a varying length of residential care based on the patient needs, and they would get a very intensive treatment program. They would be stepped down to either going to the hub or to the spokes out in the broader community. But these would all be in one healthcare system, in one medical record, so that this could be tracked, and so that patients who dropped out of treatment, we'd be able to monitor them. We would have contingency management set up to move patients through different levels of care, to keep them engaged along with the medications that they would get. Let me give you a little more detail of this. So we're thinking that we would be starting this in Jeddah. Jeddah would be the test case for the first round of setting this up. This is the Mabar Center of Excellence. It's a 500-bed, it's under construction right now. It'll be a 500-bed residential care for all of those specialties. 200 of the beds will be for psychiatry and substance use disorders. And this will be the area, this will be the group that will be working with. 200 beds is a lot of capacity. This will be an essential resources for individuals with severe substance use disorders and mental health disorders requiring the highest level of care. This will provide an opportunity to provide a complete assessment and development of a coordinated treatment plan. Within this center, they'll have comprehensive assessment, initiation of abstinence, psychoeducation, Family education and therapy, we intend to create a very active program of family therapy. Family in Saudi Arabia is it's important everywhere in the world, but particularly in this society, getting the family engaged in the treatment process will be essential. Medication, we hope to have buprenorphine and methadone and the alcohol medications available and stimulant medications if they ever exist. The staff there will be given a good deal of training with motivational interviewing, with relationship building. With CBT, we may have some contingency management that we're able to start there. And we'll get them involved with a program of exercise. Now, I said the other stuff that I talked about before was Tom's stuff. I'm a big exercise guy. We published 10 papers in the last few years on the role of physical exercise, and a group in Montreal has just done a couple of meta-analyses on the value of physical exercise in restoring neurochemistry and getting people more physically healthy and to provide a new alternative behavior. So we hopefully will be incorporating a physical exercise regimen in the Mabar system. The next system will be dealing with the Faqih hospitals. Now, these will be the hubs, the regional hubs, where we will have an inpatient unit where we'll be able to do acute care for people who need medical withdrawal treatment. They certainly have an emergency department. They have, an acute care medical hospital. We'll institute screening for all the patients that come in with medical issues. They'll all have mental health and substance use disorder screening. And they will be, for many cases, the patients will be coming in there if they need detox or if they need to start medication. They can initiate their medication in these hub centers and then have their care coordinated with the outpatient spoke clinics. They'll be providing assessment treatment for substance use and mental health conditions, screening, withdrawal, management and detox, medication assessment, stabilization, the creation of the treatment plan, at least the initial treatment plan, and then this transition process. There have been some research done, Jim McKay at the University of Pennsylvania and others, on how do you increase the rate of transfer of people from a hub center like a detox program into the community, where clinics may be located diversely distributed around the community. And so we have some issues there that we're planning to implement. Obviously, if they start into a program of cognitive behavioral therapy or community reinforcement or some other treatment program, it will get started there and then transition into the community. And that's where, if we're using app-based care, we'll be starting them into the use of their apps while they're in the hubs. Once they get to the spokes, this is where most of the treatment will occur. This is where their patients will be spending the majority of their time. In these clinics, we'll institute screening for the patients that are coming in for all kinds of medical care and other medical support services, screening using things like the assist and other instruments. Will be instituting screening throughout the medical system, not just the emergency departments, but the patients in the hospital. Those who come in for substance use disorder will be able to get their health care in the same clinic so that they're not splitting out their addiction care from their general health care and general mental health care. All of it will be able to be provided on an ongoing basis in these spokes. Educational materials will be hopefully using AI. There's some great AI screening programs right now that we will be able to see how well they fit for the Faqih system. If there's a need for sober living or recovery homes, that's something we'll assess over time. And there, as I said, there'll be real focus on getting people to stay involved. Retention will be our major focus. How do we keep them connected to the healthcare system and keep them coming back to receive both substance use care and healthcare, general healthcare as well? The services in the spokes, screening, brief intervention, medication management, behavioral support, getting them to exercise, to continue that, self-help meetings and the like, ongoing family assessment as well. So this is kind of the idea of what we think would be useful if we could implement it for the FAQI folks. Priorities: evidence-based interventions, enhanced strategies for transition and retention, expand assessment for substance use and mental health, and optimize the use of AI and technology. Challenges, as you'll see, are workforce, because there is no workforce right now. There is no trained workforce. So this is completely pie in the sky unless we have a workforce who can deliver this, and a workforce trained with this in their head as what treatment and recovery should be. And we've never had that before. So this provides an incredible opportunity for us to develop a workforce who understands addiction as a chronic illness, and that moving people through a process into recovery is what we're hoping to do. And hopefully I'll be able to insert a little harm reduction in there as well, but that will be something we develop. Now the other challenges, of course, Dr. Manal would like us to have it ready next week to go, but luckily the Mabar facility will be ready in 2.5 years. So we can figure out a lot of this between the hubs and the spokes, hopefully in the next several years, to be able to then have it available as a source of referrals and as a continuing care structure for patients who are treated in the new center. I will stop there and turn this over to Madam Workforce.
Great. Thank you, Professor Rick. And while we're getting this up on the screen...
Do you want a hand microphone, maybe?
Oh, shall I do that? Usually most people say my voice is loud enough, so I don't know. Can most people hear me? No? No. Okay. All right. So while we're pulling up the slides, I thought I'd give you a couple of quotes, really, about workforce, because I think they're relevant to what I'm going to be talking about. But one is, and I say this, and you would possibly expect me to say this as an educationalist and as a former dean, education often is the forgotten child, so to speak, in a family, in the sense that it's, and I don't know if it's your experience, but often that when you go to these kind of presentations, you hear about all the innovations and what is exciting and what's going to happen, and then somebody says, oh, and by the way, you have to train them. So I'd like to flip it on its head and say you have to train them first because it's really important. And a couple of quotes which kind of set the scene are, the only thing worse than training your employees and having them leave is not training them and having them stay. I think we can all identify. An organization's ability to learn and translate that learning into action rapidly is the ultimate competitive advantage. And I think that that particular quote for me is super important, because I think actually the vision that we're seeing with the FAQI group, and in all fairness to Dr. Manal and her team, is that they actually get this. They get the importance not of building only the building and obviously having these superb state-of-the-art services, but you can't do it without the staff and you can't do it without the people. So really what I'm going to try and do is take you through a little bit about the sort of the blueprint, and hopefully some of this resonates with you. And I want to particularly thank Dr. Manal, because she will hopefully see some of what her thinking is reflected in this presentation as well. So to start with, the presentation objectives will be about how do you ensure clinical day one readiness, which is really what we're trying to achieve. Outline a fit-for-purpose postgraduate diploma, particularly for the FAQI group, but we see this as being the beginning of something very exciting, not only in the kingdom, but also within that particular region, and ultimately has opportunity to ripple out and cause some interesting, I think, resonation across the world, because often we are very focused on the West often, and I think it's going to be really quite interesting to see a brand new program really putting us to the test and being state-of-the-art. And then building the sustainable workforce pipeline, which is aligned with the vision of the kingdom, which many of you will possibly know is the 2030. Most countries have national development plans, and the kingdom is no different to that. So the context and vision really is to establish a national postgraduate program that sets a new benchmark for addiction treatment and rehabilitation. This pioneering initiative will, and these are very ambitious as you can see, but I think you would agree with us that they are essential. So equip professionals with advanced evidence-based skills in addiction care, cultivate a new generation of certified and accredited experts uniquely prepared to meet the Saudi evolving needs, ensure financial stability and sustainability through a dedicated income stream, supporting a scientific chair, enhance the national public health by improving outcomes affected by substance use disorder, and harmonize global best practices with the Saudi Arabia's cultural, religious, and system context, bridging international excellence with local relevance. And I mentioned about aligning it with the Saudi vision of 2030. I just kind of hinted that. Please read, if you're not familiar with that vision. But I think you will see that all of what those objectives are really do align very nicely with the three pillars of vibrant society, thriving economy, and an ambitious nation. I think Professor Rick has kind of told you how things have evolved. And if you haven't been in that part of the world for some time or have never been, I can tell you, having recently had the privilege of being in that country and hosted beautifully, I have to say, how things have really shifted and how dynamic the current progression that is happening there. So it's really worth a visit if you're not familiar. That said, there are the challenges that you've just heard. And there was a piece of work done by Lee et al. Just very recently, which looked at actually some of those critical challenges within the workforce. And as you can see, there's a shortage, according to the analysis done by that team, of 10,400 professionals, primarily nurses and psychosocial care providers, accounting for 98.9% of the gap, with only 49.2 providers per 100,000 population, so far below the high-income country benchmark. So that is really telling you that there is a huge opportunity and space for this development. And I think Dr. Manal was sharing with that there's a lot of mushroom happening in terms of people coming forward, but really, and I think this again is to the credit of FICCI, they are really wanting to make sure that it's not just about providing something, but providing quality. And I think hopefully you're going to hear in the blueprint that we're suggesting we can hopefully support and meet that need. And of course, the cultural integration, which has to be a bedrock of all of what we're talking about. And again, this unique opportunity to lead on transformation. So again, future-proofing, we're talking about, it's all very, and when you're thinking about blueprint for academic programs or indeed training programs, we often think about the here and now. What do we need now? What's facing us in the clinics now? And that's, of course, relevant and important. But as educationalists, as training providers, we need to future-proof. We need to think about what is the next 10, 15 years coming. What are we going to be seeing? What are we facing? Because the people who come into our training now will be addressing that, not what is right here in front of us. So how do we start thinking ahead, even though it may not feel that it's important at the moment, it could be, and it could be incredibly relevant. So bridging for readiness to sustainability, we need a structured professional training pipeline. So this is not just a one-off. So you get a cohort through, you train them, and then they disappear, which I think we're all familiar with. You invest in people and all of a sudden they're gone. But how do we ensure that we bed this in strategically so this pipeline is continuously producing the workforce that is required in terms of need? And then enhancing capacity, quality, and more importantly, retention. So career ladders. How do we actually show people it's worth taking these courses because we can plot your career for you, and even though you're a novice at the beginning, you will get to the mastery and hopefully at some point seniority. So some of the key elements to assist with that, or essential elements, we would argue, is local ownership and leadership. And I'm very pleased, as you can hear, we have that, and we have certainly got key people in key positions to guide and to support. There is a tendency often for experts to drop in or parachute in to local circumstance and sort of say, this is how you do it, guys. And local people are going, yes, that is interesting, but that doesn't exactly fit the context in which we're talking about. Or indeed, even though what we're saying as flown in sort of experts is sensible, it doesn't resonate. It doesn't, you know, in any communication, there is the sender of the message and the receiver. So we may think we're sending a beautiful message, but it's not being received, and one needs to be really super aware of that. Local people advising, guiding, and steering that language and that cultural adaptation is clearly essential. And that's where the cultural contextual relevance needs to be absolutely bedded in from the beginning. Regulatory and academic alignment. Every country, as you know, has its own regulation, has its own commissions. You cannot do anything unless you have these people with you from the beginning. So again, if you kind of come along with already a pre-packaged or an adapted from somewhere else, possibly not going to work as well as if you start from the beginning, ideally with those people at the table with you, bringing them with you and guiding you and saying, no, that's not going to work, this is going to work, and then being adaptable and pivoting to that. So again, hugely important. Faculty preparedness. There isn't a workforce. Is there a faculty? Likely, probably not. So how do you manage that? How do you bring your current faculty up to and skill up to where you need them? But also how do you maybe bring in, and there's certain things like flying faculty to begin with, they come in, they support. But again, the eye is always on how do we sustain this locally so that eventually flying faculty is not required and the experts can go home, so to speak, because you've built up your own expertise in country. Stakeholder involvement, so as much as you need local leadership and of course people in positions that can open doors, make sure the phone calls can happen, but you actually need your buy-in from a much broader set of stakeholders, and that is professional organizations, people who've already been in the field, maybe not exactly doing what you would like them to do, but ultimately have a voice and a very important voice to contribute so that it's, again, shared ownership. And of course, the curriculum and learning design has to be contextualized into what is that culture, and we'll come back to that in a moment. So who are we thinking about? This is both allied and medical. So we're talking psychiatrists, psychologists, nurses, social workers, generic in that sense, counselors, primary care physicians, public health professionals, and indeed people from law enforcement. There is the alternative incarceration, a relatively new concept in certain cultures, but again, work for that needs to be thought of now so that you can future-proof going forward. Who would be the faculty? Well, again, one would expect that you'll have your addiction psychiatrists, leading experts in the medical and psychiatric aspects of SUD, and we're in the best venue at the moment, many of them sitting in this room, and I know that ISAM are very much partnering on this project, so that's a big tick, which is wonderful. Clinical psychologists, of course, you would expect, nursing leaders, skilled professionals who have frontline experience, Islamic scholars who can guide the program aligned with cultural and religious values, healthcare policy advisors equipping the participants with strategic insights for leadership within that evolving health systems coordinators. And then I've mentioned the future-proofing the curriculum. So over the next 10 to 15 years, the addictions field we know will be shaped by a convergence of scientific, social, technological, and policy trends. Professionals, educators, policymakers will need to adapt to these evolving forces to ensure effective prevention, treatment, and recovery systems. And I have to say, I was recently, and I know there are some colleagues here who were also recently at a beautiful conference in Qatar at NAFOR. I had the privilege of being able to attend there a few weeks ago. And I have to say that the title of that conference was Precision Medicine and Addiction, and it blew my mind, actually, some of the work that's going on in this field. And so when I was looking at the future-proofing, these are key things that we need to be considering because it's already emerging, it's already happening, certainly in the neuroscience and precision treatment advances. We've growth in behavioral addictions, which you've heard actually Prof. Rick talk about. Substance use trends and polysubstance use constantly evolving. So, you know, nobody can feel certain about what is happening now that will not be happening further down, and regionally it's extremely different. Workforce and professionalization challenges, we know that that's emerging also. Integration of mental health and addictions has happened in some parts of the world, but it's still, that sort of principle is still evolving, but we all know that they're sort of brothers and sisters, those two aspects, and if you don't think about them in an integrated way, really we're starting from a very challenging position. Technology and AI and digital If you haven't checked it out, I would really suggest just even Googling. The amount of work that's happening in this space is phenomenal, from wearables in terms of predicting whether somebody is going to overdose and then alerting the primary physician, to all sorts of AI, looking at brain imaging. I mean, really, the work that's happening in this space is phenomenal and really needs to be reflected. The globalization and migration one can't ignore, but populations are on the move. We're seeing it even more and more in such an unstable world. So how do we figure out that we're not just looking after our indigenous population necessarily, but there will be populations moving? How do we start to think about that? Policy shifts, which constantly evolve, as we know, with different administrations. I won't say any more, but decriminalization trends, of course, fits into that. And then social inequality and structural determinants, huge aspects. So thinking about a curriculum, you could feel somewhat overwhelmed because you're thinking, how do we start reflecting all of this? How do we start managing this? But this is where your curriculum design team will need to sit down and unpack that and make sure that the evidence that is available is now starting to be threaded through any curriculum plan that is being looked at. So designing and developing a postgraduate pathway that has flexibility to span certificate to diploma to master's with opportunity to support discipline-specific tracks and integrate clinical practicums requires a structured and collaborative process. So again, very, very pleased to say that I'm a member of, obviously, ICU-DDR, which has a very large contingent of allied health, and particularly credentialing and training, is partnering with ISAM, is partnering with the FACI group. So hopefully that nice sort of overlap of those sort of triangle of people coming together will hopefully be able to meet all of this. But the key things, again, locally driven, which you've heard me say, the global academic partnerships, of course, ICU-DDR with ISAM, cultural sensitivity, blended learning so that there is in-person and online, flexible pathways with entry and exit points, and potential also to embed in your program a concept or a model which is known as RPL. Certainly in the UK, it's language we use, which is recognition of prior learning. So that allows for you, if you have people who have been for a long time in the field, but have never done the formal education, i.e. do not have the masters in addiction, for example, but really have learnt on the job and are actually quite advanced in their understanding, the last thing you want to do is say to them, well, you can't work in our facility unless you have this diploma, and then exclude them. So rather than push people away, it's about engaging people. So a recognition of prior learning model allows you to say to them, we have learning outcomes that have been mapped. If you can do a short portfolio to demonstrate your prior learning and experience, we will then review and assess that and award you the diploma because we can recognize that you already have gathered this experience and learning through other forms and other means. So it's allowing you to then recognize that expertise that might be in the team without necessarily alienating. So those need to be built in alongside stackable credentials, availability, very important, of the clinical practicums. Again, the fact that the FACI group has a university, a medical school, plus then the facilities that you've just been hearing, the ability for those practicums could be very much available. And indeed, some nice ideas came out even earlier today about rotations and potentially secondments abroad into other facilities, perhaps with ISAM experts who could take graduates of that program and then have them for 3-6 months to work alongside and supervise and mentor. The technology, I think, goes without saying, and ethical legal compliance, of course, with the Saudi laws and the regulations, and then language. Choosing language is an interesting one, because there is no, as far as I'm aware, standard course in addiction in actually Arabic. So I think this is a nice challenge for us to think about how do we manage the language issue. Most are in English, as you know, but I do think that there is value in thinking about the alternatives. So again, just to finish and sort of bring us to a close, one of the things that is key with any curriculum design is not actually at the beginning. It's a bit like any project management. You always start, don't you, with your deadline and work back. Similar in curriculum design, you think about, well, what does my graduate look like? at the point of completing a course. What do I want them to be able to do? What will they be able to achieve? What knowledge, skills, and attitudes do I want them to have? So thinking about your graduate and working back also helps you in terms of deciding and designing what that curriculum should have. So that's kind of at the heart of your guiding question. What are the expected knowledge, skills, and attitudes of your ideal graduate, and how do these attributes shape what our graduates should look like in professional practice? And you can see then some points that guide us on that. But that's really where you start with your curriculum design team. So given everything I've said and about that future-proofing, about thinking about where we're going, travel of direction, what would a proposed syllabus look like? These are just kind of markers, but I suspect you can see where the thinking is going because of what I've just presented to you. So really looking at 2025 to 2035, 10 years roughly for curriculum is always good. Building into your curriculum design constant evaluation and updates. Okay, so but thinking now already 10 years hence, what will our graduates look like? How will they be fit for purpose? So we're looking at module content highlights would need to be covering obviously foundations, neuroscience, diagnostics, interventions. You've heard Prof. Rick talk about the CBT and sort of medication assisted treatment, harm reduction. I mentioned it, Rick, you'd be pleased. Digital health, of course, electronic monitoring records, AI tools, telecare, trauma. Everything, as you know now, is pretty much trauma informed, so that needs to be bedded and threaded through. Practicum, supervised clinical experience, research basic methods, quality improvements, and an element of self-reflection and looking after the professional. We do need to, in terms of leadership, also help people look after themselves. We're not very good at looking after ourselves as professionals. We tend to look after others very well, but what about ourselves? And that's where supervision, mentoring, coaching, but actually giving people time to reflect on their practice and their own wellness is really super important. And by acknowledging it in a curriculum, you're sort of giving permission, so to speak, that people should be able to do that. So moving just slightly again with the syllabus, going future skills, so embedding personalized addiction medicine with the genomics, the biomarkers, AI-supported diagnostics, prediction, virtual AR-based therapies, behavioral economics and treatment, environmental and family systems approaches. The diploma must evolve to reflect technological and scientific advances. By embedding these areas, we ensure that today's students are tomorrow's leaders. So still relevant in 2035, super important. So workforce sustainability then attached to that. So my last couple of slides really are just a note. Particularly the next one I'll show you is very detailed, but it's really just to give you a flavor of the things we need to be thinking about. So you develop your program, you go ahead with all of that, it's beautifully laid out, everybody can take it, but then you need to look at your annual graduate intakes and matching that to demand. So you're never resting. You're never actually stopping saying this is where it needs to be. There is a constant sort of loop of review and reflection. Career ladder integration. So do you have positions and is your course sensitive to people who are at a novice stage to an advanced stage? So that entry and exit points need to be flexible so people can enter in further down than necessarily at the beginning if they can show prior learning experience, for example, so that you're meeting all needs within that overarching journey. Ongoing CPD, continuous professional development, so that it ties in with credentialing. Again, we are very good at training people in a sort of an immediate and saying, well done, you've got your degree, out you go. And then, of course, we do have professional recognition on a periodic basis just to maintain, but that tends to be generic. We don't have specific specialty credentialing. So there is a need really that just because you've done your addiction diploma, that there isn't going to be an ongoing need for lifelong learning. So by having a credential bedded in your curriculum at the end, people will come back every 3 years and have to demonstrate that they have kept up their learning in terms of CPD offerings. And then evaluation metrics, which I'll speak with in the last slide. So this is all about long-term workforce planning, matching clinical demand with graduate output, retaining top talent through, forgive me, the spelling error, continuous development and clear career pathways. And it's a very busy slide, but just to give you an idea, most importantly, is the metrics. and not thinking about those after you've developed your curriculum. The metrics have to be bedded in as you're thinking your curriculum design. So as you're going through and designing, you're looking at academic and quality learning KPIs, professional and credentialing KPIs, student engagement and retention KPIs, graduate outcome KPIs, system and policy impact KPIs, and then operational administrative KPIs. And there's some examples of all of that sort of under each of those pillars. But think about that data that you're gathering, because if that's systemized from the beginning of your program and you're gathering it in a systemized way, now you start getting workforce data which could become incredibly relevant to the future-proofing again, because you're going to be constantly looking at those metrics as they come back at you from your program, which will inform you from an evidence base. Not just do you think the program is going well, but actually from an evidence base, but taking it from all of those angles. So I highly recommend that when you're thinking curriculum, you're always thinking about the research around the workforce and how you gather data in a day-to-day basis so that it becomes natural to the program. And so a roadmap, well, you've heard that it's ambitious. I hope that it can be achieved. But this is a rough roadmap that we're going to be trying to work to. So as you can see, give or take 1 to 2 months of planning, faculty onboarding, and getting the right team together. We've already had our first meeting around that this morning, so that's a tick for us. 3 to 4 months in terms of curriculum design and planning and writing. Maybe around 1 to 2 months to get the accreditation submission and making sure that local accreditation professionals are looking at this for us and hopefully signing it off. And then 2 to 3 months to maybe pilot some materials with colleagues in the field, not necessarily leading to the diploma, but getting them to test the materials. Are they fit? Do they resonate? Have we got it right? And people in this audience could very well be very nice stakeholders to that pilot. And then 6 to 12 months to a full launch, generating revenue, which of course is important, but more importantly, building that alumni community of practice, which is going to be really the cornerstone of the continuation and the sustainability of this. So it's a bit of a blueprint. We're really ambitious. We hope that we can achieve it, and maybe in future congresses we can come back and tell you how successful it is. So thank you very much.
So thank you very much for these wonderful talks. I'll be thinking about behavioral addictions, focusing on the Saudi context, as well as more broadly considering jurisdictional and cultural considerations. Here's a listing of my disclosures. And as I've spoken on previously, and as we heard, how people are conceiving addictions has changed. It's only been within the past decade or so that behavioral addictions have become more established. They were debated in the early part of this millennium when questions were raised about whether behavioral addictions existed and whether we could consider behaviors like gambling as behavioral addictions, as the focus of behavioral addictions. Now, it should be noted that gambling disorder has been in the Diagnostic and Statistical Manual and the International Classification of Diseases for a longer period of time. So of the formal behavioral addictions, it is arguably the most well-studied. Gambling disorder and other behavioral addictions share features with other addictions, those focused on substance use, particularly with respect to elements that might inhibit people from seeking treatment. And these factors that relate to shame and guilt and ambivalence about changing behaviors might differ according to different cultural contexts, whether it be religious or social norms or other factors. That being said, there may be commonalities that also cut across different cultures and jurisdictions, particularly with relationships to mental health and other addictive concerns. So actively screening in an open, non-judgmental fashion, making people feel safe, is an important consideration. Also, as we've heard, a lot of what we know about addictions, but particularly behavioral addictions, come from Western cultures, data from Western cultures, particularly from North America and from Europe. So some of the data that we have for treatments for gambling disorder, for example, this treatment algorithm is largely based on data from North America and Europe. But it provides a framework for which we can consider how to approach people in different contexts. These are a pharmacotherapy algorithm that we propose for gambling disorder. However, behavioral treatments are the mainstay of treatment. So we proposed a more complex treatment algorithm that was published in Nature Reviews Disease Primers, again based on largely Western data. Now, as DSM-5 was being considered, there was recognition that the internet was playing a more substantial role in people's lives. And whether internet addiction should be the focus of a disorder was discussed. And the most data at the time suggested, and these data were coming from Asian jurisdictions predominantly, that gaming behaviors on the internet were linked to deaths when people were not adequately caring for themselves in marathon gaming sessions in internet cafes, as well as parents leaving their children unattended and children passing. So the DSM-5 substance use disorders work group included criteria for internet gaming disorder in the research section. However, what we know about treatments for internet gaming disorder lag behind even that for gambling disorder. Like with gambling disorder, there are no FDA or regulatory approved medications with indications for internet gaming disorder, but there have been some randomized clinical trials suggesting that some medications like bupropion or escitalopram may help individuals. Similarly, there are emerging data that neuromodulation, non-invasive brain stimulation may help people with gambling disorder or internet gaming disorder. And in the United States, there are options for residential treatment, not the same that we heard about earlier today with the hub and spoke model, but one of the concerns about treatment in the United States is that oftentimes addictions, and particularly behavioral addictions, are not covered by insurance, leading to concerns about people receiving treatment. Now, when ICD-11 was being generated, behavioral addictions arguably took a more prominent role where gambling and gaming disorders were included. Compulsive sexual behavior disorder was included, but as an impulse control disorder, not as a behavioral addiction. But other widely engaged in behaviors on the internet, like use of social media, were not included. So there was this proposal that Matthias Brandt and colleagues put forward that we could use this other specified disorders due to addictive behaviors as the diagnosis term. There have also been instruments that have been developed, tested in Europe and Germany, translated and validated in some Asian countries like in Thailand, that assess for specific internet use disorders, specifically gambling, gaming, pornography use, shopping and buying, and use of social media. And so this is a rapidly changing field. We recently tried to synthesize the data succinctly with a focus on clinical aspects, so how to provide treatment for people with these conditions. We've also noted that in addition to the DSM and the ICD changes, there have been changes to some models that have been proposed to focus on internet use disorders. One of the more prominent models that Matthias Brandt and colleagues put forward is the interaction of person, affect, cognition, and execution model. The full initial model is shown here. too small to read, but core elements of the model focus on how people respond to different external and internal stimuli, how this triggers responses that influence behavior that then lead to reward expectancies that over time lead to differences in terms of responses more linked to cue reactivity and craving that are under less control, leading to more habitual behaviors that are more compensatory in nature, leading to affective and cognitive biases. We also more recently updated the model to take into account the clinical observations that these changes in compensation and gratification that occur over time in addiction processes are not linear in nature. And so clinicians should be able to adapt. The IPACE model also has more recently been modified to take into account some cultural considerations. And in this case, we reviewed the literature on articles coming out of East Asian jurisdictions and took some of the IPACE components initially proposed and highlighted here in orange and considered how personal factors might differ or might be specific, might be worthwhile to consider the differences in East Asian cultures with respect to personal factors like academic stress, how families are organized within a more collective value-driven fashion, how some of the affective factors relating to shame, this idea of face within Asian cultures may be more relevant to the IPACE model, and how social comparison may differ in East Asian cultures versus, for example, Western cultures. Then we also considered differences in cognitive factors as well as execution factors relating to school policies and how jurisdictions in different regions of the world may operate. And so there may be different protective factors and risk factors that are important to input into refined models, and this has implications for how care might be delivered, for example, within Saudi Arabia. Now, some of the data that has emerged about addictive behaviors out of Saudi Arabia, there have been some studies, but like in many other jurisdictions, the studies are relatively limited at this point in time. Like in other jurisdictions, there are concerns, particularly among young individuals in the Kingdom of Saudi Arabia with respect to problematic use of digital technologies, and there are relationships with other mental health concerns, particularly anxiety and stress. Now, as we heard about in some of the prior presentations, generating a workforce that is going to be able to address not only substance use but also addictive behaviors is a worldwide concern. And so this is a photograph from a WHO meeting focusing on education and training of medical doctors on the prevention and management of disorders due to substance use and addictive behaviors, recognizing that groups like ISAM, where I was representing ISAM, but also groups from around the world need to work together to take into consideration the different cultural factors that may be important to optimize treatment in different parts of the world, but there are ways in which we can work together in these training efforts. So in conclusion, how best to define behavioral addictions remains debated, but it's going to be important for us to train healthcare professionals to identify affected individuals and to help them and their families and others impacted by addictive behaviors, and to use empirically supported treatments, and to understand that Perhaps the empirically supported interventions from other jurisdictions may or may not apply optimally in other jurisdictions, so we'll need to also gather information from those jurisdictions to determine the extent to which they may or may not. And in this process, we'll need to keep in our minds how specific aspects of culture as well as legislation and other jurisdictional specificities may influence the identification and treatment of individuals as well as prevention of problems. So I'd like to thank a large number of individuals, funding agencies, and thank you for your attention.
So thanks a lot, Professor Krausen, Dr. Jean Carmel, and Professor Mark for the presentation about the project in Saudi Arabia and the work that have been done between ISAM and ISODDR. So we'll be open the floor for the question from the audience. If there is any question, please let us know so we could address it. Yes, yes.
Thank you. I have one question. You mentioned it's. I thank you first for this overview, and I would like to ask a question related. You mentioned the fragmentation of the system, of the services, and working with spokes to increase the availability of treatment in the community. And so do you consider development of transition from the inpatient to the outpatient services, or how to work within the community, with and in the community, do you imagine mobile teams or something like that in this context?
Well, I think the first thing is to have it in your mind as the natural thing to do, as opposed to the current situation, which is everybody thinks about their piece, but doesn't think about the continuum as the goal. Once you do that, I think there's going to be great use of app-based care, wearable things for reminders and getting people back into treatment and keeping them connected. The nature of the relationships that are developed between the patient and the staff people, if there's good focus on the staff having that as a message throughout the system, that not only are they interested in what you're doing today, but they're interested tomorrow that you're seeing a person at the next stage of treatment, and that handoff is made thoughtfully and with communication to the next level of care, that can be important. We've actually done some work with patients with severe mental illness using contingency management, where they actually earn gift cards for showing up at the next level of care. There's a variety of things that can be done. I'm not sure what will work in Saudi Arabia, but I think going into this with that as the goal and measuring, obviously measuring, if you start 100 patients in treatment in the hub, what proportion of them actively engage in the spoke, and keeping track of that and having an ongoing process to focus on that as an important metric. I think all those things, we don't have the answers yet, but we haven't really worked on developing it yet as a standard, but that hopefully we can make some progress.
Thank you, everyone. I'm Gavin Bart from Minnesota, United States. I mean, Rick, you're now in Vermont, so you have incredible awareness of the hub and spoke. But you know, one of the great challenges is patients with substance use disorders have been so traumatized by their experiences in healthcare. Once they enter into a system where there is an understanding individual, an understanding provider, they therapeutic effect to that person, and they don't want to go anywhere else because they've already made themselves vulnerable by telling their story to this person. And so people end up at the hubs and will never want to go to the spoke, or they end up at the spoke and they never want to go to the hub because they've already established that relationship. And so I think it's a long way of asking a question, which is, to what extent in this process have you engaged the end user's voice to help model it, to see whether they're even willing to do these things?
Gavin unfortunately brings reality into the picture. I hate it when we have to talk about reality, but yeah, clearly, and as you said, he's referring to, in the state where I live, the small rural state, we have a hub and spoke model for buprenorphine treatment. People start in one setting and transfer into more rural settings. That was the way it was supposed to work. But what eventually happened is exactly what you're describing. People go into the spoke, they meet a doctor, they start the medicine, they stay in the spoke, and if the doctor says, you really need a higher level of care, we need to send you back to the hub, very difficult to get them to go. They develop this very powerful relationship. I think there are some things that can be done to address it. I don't know how successfully, and as you say, we're going to have to look at that here with the people and talking to them about their relationship with their doctor and their clinicians. And I did a project once in Los Angeles with a residential program. I was running an outpatient clinic, and we wanted to get patients from the residential program into our outpatient clinic. I went to the site of the residential program once a week and ran a group of patients who were going to be transferring out of the residential center to my outpatient clinic. We tripled the rate of transfer because they developed a relationship with me while in the residential center. Now that may have limited usefulness on a larger scale, but I think we can develop some things like that to work on it.
If I could just add, and maybe there are some colleagues here from the UK as well, that's where primarily most of my clinical experience has been, in psychiatry. But liaison psychiatry in the UK is familiar with that sort of transition issue, in the sense that if you have liaison workers within the teams, they act as the conduit. They can often act as the bridge. So a little bit what you were describing, where they got to know you on an inpatient unit and then met you. But you can do that as part of your team mix, that there are certain colleagues, professionals, who act as a liaison and can actually almost build that relationship and handhold people from one section of a service to the next, so that there is this conduit, so to speak, but that there is a relationship not only with maybe the primary, but with somebody who works in partnership. So I've seen that work, and that is potentially one model that gets around some of those challenges. But you're right, it is a difficult.
Any further questions? Yes, Kelly, you have the mic.
Hi, Kelly Clark from the US. Thank you for the talk. I think one of the things that is so amazing here is that this is a blue ocean strategy. As Dr. Barth was picking up, and also Rick, as you were talking about making the connections and everything, we've got a siloed system in the US. And there are multiple structural barriers as we go along here, because it is just a blue ocean and you're building it from the beginning. You have this amazing opportunity. And so my actual question is for Dr. Clancy, because clinically and systematically, the models make sense. This is how you would do it. But I'm thinking, to build this, what a Gantt chart you have, Dr. Clancy. How many spreadsheet pages do you have to interdigitate to pull all of this together? And so just operationally, because the model is the model and it makes sense and that's what it is, but the operational piece, I'm thinking, how big is your team to make it so?
Could you send an email to Dr. Manal?
Can I answer? Well, I will answer something in the middle, then I'll get other questions for us. Well, You are right, 100%, Kelly. Yes, if you go on theory, everything is nice, and we keep taking pictures and so on. But the ground is something else. This is a multidisciplinary team, and this is an example. You know, I'm not shifted to my NRC. No, I'm shifted to the best practice we did with Professor Rawson and the team. It's a multidisciplinary team that's been done between the healthcare sector, Ministry of Interior, Ministry of Education, Ministry of other multiple tasks. They have justice, they have to be with us. So that's a program, by the way, we just already started teasing up the project in Saudi Arabia, and we start meeting with the other stakeholders working with us in order to prepare them for that. I know it's a long process, but over here we are introducing theory, education, practice, plus we are introducing also an experience that was successful one day. So basically, I know it will be having a lot of effort. Basically, as Professor Rawson said, from Dr. Manal and her team mainly, because we are an advisor here only, but at the end of the day, we are initiating a system that have the potential of success. Again, in 1 year, 5 years, 10 years time, but this is at least, it's been where other people ended. I hope I can answer your question, please. We have the mic, and then, yeah. Michael, go ahead, Michael, and I'll give you your mic.
Yeah, indeed, an incredible initiative combining both academia as well as service to the patient. And I had a question for Dr. Rawson. In the overall strategy, and I picked up one word on your presentation, which was the objective of recovery. How is that defined? Is that based on a long-term social integration and potential stabilization of the patient, or is it, I would say, also a regional objective of achieving abstinence for these patients?
Well, I think my answer is both. That, if you're asking, is there the assumption that people to be abstinent have to be off medication? No. The concept is many of these people may need to stay on medication as long as they need to stay on medication. And yeah, so yeah, I think that will be, and I'm sorry Manal's not here, but that'll be an interesting concept to work with, because Saudi Arabia has not, they have extended release buprenorphine, the injectable. I'm not sure they have the film or the tablet, the oral. They don't have methadone, and they have very little medication for. Methadone was available in Jeddah. Was available, but yeah, that's going to be a big issue that we'll be discussing, and obviously it's their call, but there's been a lot of discussion of getting those medications into Saudi Arabia, and it would be my hope that they could be used with a philosophy that this is something different patients need, different courses.
For the sake of the time, final question.
Hello, my name is Esther Deupman. I work for the Dutch postgraduate training for addiction physicians. I have a question for you. Well, thank you for your talk. I was wondering, you explained very clear and inspiring about the curriculum. You explained about the curriculum and building a curriculum. Do you face, and how do you cope with that, the difficulty of finding people, professionals, to enroll in this curriculum? Because that's a problem that we face. Could you tell us something about it?
I think so the question, if people, because it was quite low, is about how do you attract people into your program? And that's a really big question globally, because the workforce, irrespective of which country you're in, we're all challenged to get the addiction professional enrolled in our programs. And that really is about us still being challenged by stigma. We are the poor relation of psychiatry in that way, that people, or mental health, people don't necessarily see it as a specialist track. So again, that's about awareness raising, it's about getting it in at policy level. It's not just doing it at the educational level. You actually have to get in at the political level. And personally, from my own position now in ICU DDR, is I'm trying to do a lot of work at government level around credentialing. Because if a government if you can get a government to accept that in order to run a providing service, that the staff in that service have to have the training, they have to be accredited, not just as a doctor, but they have to show that they have the credential appropriate to deliver the services. The minute you get government buy-in, now you're already starting to get a career at it that's recognized, and people can see the investment. If you don't have the buy-in at the policy, government level, you are struggling. So for me, that's where I'm spending a lot of my energy now, is looking at government buy-in and development around credentialing, which then opens the doors to the postgraduate courses. People see the value of that. So it's kind of going the other way around. But it continues to be a challenge. So again, stigma is our enemy ultimately. Yeah, you're welcome.
Well, thanks a lot, everybody. Thanks a lot, Professor Rawson, Dr. Carmel, and the team, Professor Mark, for the nice presentation and proposal for Saudi Arabia. And thank you all for attending this session, and hope that it's interacting. So it's time for lunch now, and hopefully we'll see you at the closing today. Thanks a lot.